Hey,
oh, cool.
Good. We're live. I'm Dr. Robert Graper. This is Dr. Garrett Harper at Graper Harper Cosmetic Surgery. We are here at 6 o'clock cocktail hour, and both Dr. Harper and I are bourbon fans and collectors. So Dr. Harper got a new one, and we're trying it out right now. We hope you're comfortable at home and having dinner or getting ready to have dinner, or maybe having a beverage yourself. So we're talking about breast things today and body things today, but for those of you at home, if you have questions about face and any other part, or skincare or lasers or cool sculpting, feel free to post the questions.
Right, we're here to answer any questions, but we wanted to focus tonight specifically on breast and body, but we're not eliminating any questions, so just keep them rolling. And if you want to share with us what you're drinking, that's great as well. Like Dr. Graper said, we were both kind of bourbon fans. So I picked up something from my friends at State Line tonight. It's a Wyoming whiskey. It's a straight bourbon whiskey finished in sherry casks.
Nice.
So it's a double cask, 100 proof.
It's lovely.
Cheers.
Very smooth.
So we'll start off, if we're going breast and body, obviously the breasts are kind of at the top. So we'll start with that. Talk to me a little bit about breast augmentation and breast lifts and breast reductions, and just kind of what your philosophy is when a patient walks through the door and says, I'm here about my breasts.
It's springtime. People are looking forward to summer, and when they think about summer, less clothes, and they start thinking about their figures. And breasts are a really fun thing to do. They dress up any outfit, and of course, everybody wants to look trim, and liposuction, tummy tucks do that. You've taught me some things. I have always been a submuscular implant guy, mostly because the submuscular was thought to have the less of a capsular contraction rate where the breasts get firm, and the mammograms were better. But you taught me through your breast reconstruction experience that those issues with new implants have been resolved. The capsular contracture was really never about being under the muscle. It was about bacterial infection.
Right.
And so I'm starting to do more of those that you've been doing for several months.
Right, and so I think that the new implants have afforded us a great luxury. And I tell almost all my patients, I say, you know, there used to be two camps, right? And I remember at the breast meetings, one camp was by my former chairman, Dr. Rod Hester at Emory, who to this day I think is one of a few of the best breast surgeons that I've ever watched operate. I mean, the man was phenomenal. He's since retired. But, you know, he used to say, if God intended for the breast to be underneath the muscle, that's where he would have put it. So he put all implants above the muscle. And I think that there were some people that wasn't the right decision, right? I mean, in his hands, he could pretty much make anything look gorgeous, but you have to be able to, you know, reproduce what you're taught at some point. And then there's a faction of people who would get up on the podiums and they'd say, that's nonsense, breasts, all implants should be underneath the muscle. They're more natural, they look better. And I don't think either of those camps were necessarily correct, because I think you really have to fine tune it to the patient. Exactly. I think there are some patients that their anatomy, whether or not they have a big, thick pec muscle, that if we overlaid that on top of an implant that maybe wasn't a high projecting implant because they didn't want that projection, I think you can make them look more artificial by having the implant underneath that bulky muscle. And conversely, I think if there's some people who have a paucity of good quality tissue in the upper pole and they want a big high profile implant, I think the takeoff will look less natural if you do that. So it's really key to listen to what your patient's goals are, but also to evaluate your patient. You know, that's why we do these physical examinations. That's why we do our measurements. And that's why, you know, you and I both say to our patients, there's some implants that are off the table. I mean, we're not the breast police, but we're not going to put our patients in harm's way and ourselves.
So who's the perfect candidate for subglandular augmentation, and who is the patient that you'd say, no, this is not the right thing for you?
So the number of patients that are not a candidate for subglandular augmentation are getting fewer and fewer. And the reason for that is because the implants are getting nicer and nicer, and they're getting more cohesive. And so what you have to be able to do is you have to have a trade-off. And the more cohesive the implant, the firmer it is. And so you have to be willing to have that firmness to the breast implant if you want to stay above the muscle and you don't have a whole lot of your own tissue to cover it. If somebody has great quality tissue, has a certain thickness to the upper portion of their breast, they're all candidates for it. And seemingly, I really can't think of a good reason not to be above the muscle in that patient population. Now, there's some people who are uber thin, and we know that.
And they don't have breast tissue.
That's right.
They're uber thin.
That's right.
Most of them.
Right. And no matter how cohesive the implant is, you're still going to get a little bit of rippling. But we also have adjunctive things that we've found in the reconstruction world as far as liposuctioning a little place and adding that fat into the upper pole to give them some of that. So there are avenues where I think theoretically we can get to a point where almost everybody's a great candidate. And when we started talking about capsular contracture and those things where you get this buildup of scar tissue around the implants, that data is on all comers, right? That's on people who had implants placed through the armpit, which isn't the cleanest place with sweat glands, around the nipple, which is another kind of area where we have breast ducts and glands that house bacterium. So, so long as we're doing the no-touch technique that you and I have been doing for, a decade now, and using betadine solution to clean out the pocket, not choosing an implant that's going to really stress the person's, right, and putting nipple shields on there. All these things have reduced the chance of having capsular contracture in this practice to low single-digit numbers.
I agree.
And
that's been a big improvement, using that no-touch funnel technique.
Right.
And the nipple shields has taken our capsular contracture rate, I would say 10 years ago, it was 20% to probably 1 or 2. Now it's uncommon to have that.
Right.
I mean, in wars before, it was like, oh, here's another one.
Right.
And now it's uncommon.
Well, and I think also, the advent of having implants that are these gel devices, I think do better than the saline devices. For a number of reasons, but certainly for capsular contracture as well. We've got a couple questions here. The first is, are there any specials coming up for breast augmentations?
Every day is a special.
Every day is a special. Breast augs are one of the most frequently asked for surgeries. I've got 2 of them tomorrow, and it's one of these things where springtime is kind of aug season. That's why we're kind of trying to focus this conversation on breast and body. So currently we've got great specials, and you can call the office, set up obviously a free consultation to come in to get evaluated. If you're
code word breast,
right?
I think if you say breast, you get a free consultation because you watch this seminar.
I mean, who doesn't want to be called up on the phone and just hear the word breast?
Just say breast.
That's perfect. Just say breast. That's all you got to do. And then we have another question that says, what is included in a mommy makeover? That's a great question. So when somebody says mommy makeover, what does that mean to you?
It means an evaluation of breast and body. Breasts may be small after breastfeeding because they atrophied. They may be droopy after breastfeeding. They may have gotten bigger. And we don't really understand that phenomenon, but some people get bigger and stay bigger.
Right.
Maybe it's weight gain, maybe it's the hormones, but they may want to reduce the size of their breast when they're all done with baby. So it's an evaluation of where the breasts are and where the patient wants them to be, and it's an evaluation of tummy, hips, inner thighs, outer thighs, for liposuction, or are they more candidate for tummy tuck? And so the difference between a liposuction candidate and a tummy tuck candidate would be liposuction is perfect if your only problem is external abdominal fat.
Right.
Whereas if you've got loose skin, if you've got stretched muscles, liposuction is not going to help you. And so then you need to talk about taking some skin away with the associated fat and tightening the muscles. That would be a traditional tummy tuck. If you're just taking the skin and fat away, we call that a dermal lipectomy. To confuse it further, they're full tummy tucks and they're mini tummy tucks. A mini tummy tuck for Dr. Harper and I is the treatment is going to be a smaller incision, and it's really going to only improve the abdomen below the belly button. And there are candidates for that, but certainly not everybody. So when you come in, we make a diagnosis like real doctors, and we treat the problem. And so if it's a full abdominal problem, you get full liposuction, full tummy tuck, full dermal lipectomy. If it's only a segment, the lower segment, you might be able to do a mini, which is easier and very effective.
Right. And I think what I tell patients whenever I'm evaluating is I say it's hard for them to stand in front of seemingly a stranger or somebody that they've just met, 10 or 15 minutes and had a discussion with, even though they know they're here for a medical evaluation, it's hard for them to really relax, right? There's so many men and women who, if we take our shirt off at the beach or we're in our bathing suit, we're sucking in, we're kind of holding poses that are making us look a little bit better. And so what I tell people is, if you can't relax in front of me and just totally shake it out and let it go, so that I can evaluate the muscles of the abdomen, I say just go home. Go home, get in the mirror by yourself, and just relax. And don't suck in anymore. Right. Don't fire off your core. And if you see a roundness, right?
3-month pregnancy, a 4-month pregnancy.
Or if you're just looking head on into the mirror, right? Not from the side, but you're just looking head on, and you see a roundness to your abdomen, those are your muscles that are bowing out. And so what we want to do is fix the foundation, right? Because that's what everything else gets laid upon. It's, when you're building a home, pouring the foundation's the first thing you do, right? You make sure that that foundation sits, and then you can build a beautiful house. But I tell people, if we're just liposuctioning, or if we don't take care of your muscles and just do the dermal lipectomy and remove skin and fat, we're just redraping excess skin over a non-perfect, non-ideal shape. And so if you're gonna go through the recovery, do it all. Go through it once.
And I can tell you I had at least one patient where I think she didn't relax her muscles enough, and we made the evaluation. She didn't need her muscles done. And after the surgery went well, she came in and she then relaxed and went, hey, what about this? And it's like, we're even hiding that.
That's exactly right.
So you do have to be honest when you're in the evaluation room, and let it all hang out,
right?
So we can do the right thing.
Right, and sometimes that's really difficult for anybody to do. So that's why I say just go get naked in front of the mirror by yourself and just take a deep breath and just shake it all out. We got a question: if you want to have your implants removed completely, what's the process of reshaping the natural breast? So I'll let Dr. Graper talked about how we reshape the breast. I mean, obviously a lift tends to be involved in that, but I'll also say something kind of cool that we do that sounds crazy, and I've had several patients when I have suggested it look at me
I know where you're
like
going
I
with
was
this.
wild, are the patients that have had saline breast augmentations, right? So they have saline, saltwater implants, not gel-filled implants, and they come in and they say, I want my implants out, and I don't know if I want to lift. I don't know if I'm going to like my size. I don't know what my breasts are going to look like. And that's a really simple solution.
Yeah, and especially if they've put on 10 or 15 pounds in the 20 years they've had their implants. They really don't know.
Right, so all we do is numb up a little kind of a track on the side of their breasts, and then we introduce a needle into the saline device, and we will withdraw all the fluid from it. And so you get to see what your breast size is without the implants in there, without having to go back to surgery and take them out. So you get a preview, and you also give yourself some time. I like to try to time that 4 to 6 weeks prior to surgery, so that the breast tissues have a chance to retract back and maybe get in a more natural position, and perhaps remold themselves to where the patient doesn't need anything except removal of now the deflated bag and potentially some of the capsule that forms around that. But that's kind of a decision based on whether or not the capsule's diseased or if it needs to come out even. But it really gives people a great preview. But if they do that, or if they have gel implants and they're not a good candidate for that, they're going to need their breasts reshaped. What are some of the options that you kind of give a patient if they say, I don't want an implant again, but I don't want my breasts to look saggy, and I want to maintain a nice feminine shape to their breasts?
Well, again, you make the diagnosis of what is the actual problem. Is the nipple low? Does the nipple look at the floor? Does the nipple look at the shoes? And what is its relationship to the fold underneath the breast? And ideally, you want the nipple centered vertically halfway between the mound of the breast tissue. That looks best. That looks normal. You also want to have youthful tone. So you could have a nipple that's looking appropriately, but still have lots of extra skin, and that's not as youthful. So the droop of the nipple is one thing. The droop of the whole breast is one thing. The tone of the skin, and depending on those issues, they may need just a nipple lift. they may need a whole breast lift, and you tailor that procedure to the diagnosis.
Right.
We've got lots of pictures we can show. People are afraid of breast incisions, and what you and I tell them is everything in surgery, plastic surgery, is a trade-off. Are the breasts so much better with incisions? They look so much better with the incisions that you're crazy not to do it.
Right.
Or, is the improvement small enough that the incisions aren't worth it? Now, we have small lift incisions, we have big lift incisions, depending on what the need is. And we try to guide you into the right decision for you. What's your approach?
So similarly, I mean, I think that there are ratios, there are measurements, there are positioning of key landmarks like the nipple that you talked about that are just going to define a beautiful breast. I mean, there just are. And so we'd like to get those tissues back into that location. If the patient is dead set on no implant and they need a little volume, we do have the opportunity to fat graft those patients, right? So we do some liposuction to an area, which people tend to not have a problem with, removing fat from one area, cleaning that fat, and then adding that fat back into the breast tissues, and it grafts just like a healthy skin graft would, or hair follicular transplants and those types of things. It lives off the nourishment that surrounds it, and then once the body supplies it with good blood, it stays there and gives you a nice volume that really can help add shape to a breast if the lift alone won't get you there.
I think you're right, but sometimes for me, even with the lift, that patient doesn't have enough projection without an implant.
Right.
And I understand ladies may be done with implants, and I would offer a suggestion of how about just a smaller implant, though, that would still give them more shape.
Right.
Because sometimes the skin envelope is sort of stiff and you can't shape it like you'd like to, and that implant gives it its shape. So those are things we just have to discuss.
Yeah, I think the technique that you use for the lift is also kind of really key on how to improve projection in a breast, right? We talk about the superior pedicle with auto augmentation, which is a really kind of sexy way of saying instead of discarding some of your breast tissue, we actually kind of reposition it behind the nipple and fold it over on itself to add in projection. I got a question that said, do you put drains in tummy tucks or are they drainless? I know my answer. What's your answer?
Well, I still do drains, but I would say we have experimented with that fiber and glue, and the drains were minimal output. And I think if we experimented more, we would get the confidence to maybe eliminate the drains. Otherwise, the drains are in for me anyway, till the first post-op visit, and 99% come out. So you got it for 3 or 4 days.
Yeah.
Which I don't think is a big deal. But I think the technology exists where we could go drainless. It adds expense though. That fiber and glue is fairly expensive to just eliminate a drain. It's more cost effective to use the drain. So
I'm pretty conservative with tummies, and so I'm going to sound like the old curmudgeon here. I use drains, and I use 2 drains, and I think they're great. I think that the advent of drainless tummy tucks has been looked at. I think it's great that some people can achieve that. You're not eliminating fluid. That fluid is going to go somewhere. So if it goes within the tissues instead of draining out from underneath it, then those tissue planes just get more edematous. And for me, I think that I would like to use the drains to eliminate as much fluid production as possible, get it away from those tissues, out from underneath it, out from within it, and you throw it down the sink, you throw it down the toilet, and it's not there to have any kind of consequence to the tissues. The whole kind of progressive tension suturing technique basically requires a whole set of rows of suture from the underside of the skin flap down to the muscle wall. And to me, those were always points where, you had to get it perfect, right? Because it's going to get tethered, or it'll be even less natural looking for patients. So my whole thing was, use the drains, let the patient's position and the amount of tension that's there from the removal of the skin dictate where those tissues need to fall more naturally. And for me, you know, having a drain for 1 week or 2 weeks is less consequential to the patient than having, you know, some puckering from sutures that's on the underside that sits there until the suture gets absorbed between, you know, 6 weeks and 3 months. So, you know, after a tummy tuck, the drains are not getting in the way of your social life, right? You're not going out dancing or doing anything like that for the first 2 weeks anyways. We want you taking it easy. We want you to, you know, bend at the waist and keep a straight back as best you can, so that we're minimizing the tension on your incision so that all those tissues can heal. So to me, there just wasn't enough of a downside of using the drains, and it really was just kind of all upside, besides me having to tell patients, no, I'm kind of old school, I use drains. So I didn't sound as like, oh, he's not as savvy or up to speed, but I just say,
I think very few people don't use drains,
Yeah,
because the consequences of not using a drain and having a fluid collection
Right.
are significant, and patients don't want that.
right,
So a drain's an easy thing to have for a brief period of time.
Right.
And I think your patient population may be a little different than mine.
Sure.
You know, the another good reason to be at your best shape that you can, because the better you are on your overall weight, the less the need for the drains and for a shorter period of time.
Right, which brings us to the next question. What does your BMI need to be before you do a reduction? My BMI is currently 41 and my weight is 220. So there's been a lot of studies on this, right? First of all, from a breast reduction standpoint, you know, BMI is one of those difficult things to navigate, right? Like if you looked at a lot of running backs in the NFL who may be 5'10", 230 pounds of muscle, their BMI would be ridiculously high, and you'd think that they were overweight, but they're not. So BMI is not always the best barometer to go with, but it is something that we've used in the medical community for a long time to look at, you know, statistics and to look at, you know, are you at increased risk of having wound complications? And so we know for breast reductions in particular, a BMI above 35 gives you a 14-fold increase in having complications.
And
which
true for tummy tucks as well.
Absolutely. So while there's no cutoff zone, because everybody's final weight, goal weight, is dependent upon really, you know, the shape of their body, how healthy they can possibly get. Some people have larger frames, and so we customize that, right? But I mean, if we feel like you would have a better result by losing weight and getting you to a reachable goal weight, then I encourage everybody to get there. I mean, we're busy enough to where it's not like you could come in tomorrow and get surgery from us in the next month or two anyways. So by the time you sign up for surgery, you've got a little time to lose 5-10 pounds or get yourself kind of on that, that road.
You were a curmudgeon. You said you were a curmudgeon before. I'm a much bigger curmudgeon with the weight thing, because the extra pounds make wound healing problems much more difficult. Your final result is worse cosmetically. And I know breast reductions are not a cosmetic operation. They're a neck and shoulder and back pain operation, but you know, we try to make them look pretty too. And it is much more likely to have a pretty result when your BMI is in the 25 or less range than it is when you're in the 41 range. It just is.
Right.
And then there's the health issues. You're going to get diabetes at that BMI. You're going to get knee and hip replacement issues.
Right.
You're going to have hypertension, high blood pressure. This is a warning sign, and I'm going to be conservative and be pro-health. If this pushes you to lose more weight and get at your best personal weight because your surgeon doesn't want to do your breast reduction until you meet certain goals, then that's a good thing. It's not fun. It's not easy.
Right. It's not easy to tell patients that either. I mean, you feel, you know, you don't want to get too much into their personal lives or their struggles with weight, because we all struggle a lot. I mean, a lot of us struggle with weight, right? And it's it can be different numbers that people deal with, but it's one of these things where, you know, I think I have seen a ton of patients who felt like they had plateaued And then once they get that surgery date, once it's planned, they find some extra motivation and they kind of get there. I've also had patients that have come in and their weight is written down, and I don't believe it. Like they don't look like they weigh that much, or sometimes they don't look like they weigh that little. So it's hard to just go from pounds in particular, but there's no doubt that what we don't want is for you to have surgery at a particular weight and then have a huge fluctuation from that, in either direction, because we can do a beautiful result. You can look awesome right after surgery, and 6 months later you lose 40 pounds or you gain 40 pounds, and now your result doesn't look the same, and you're upset. You spent all that money and time and emotions involved in recovering after surgery, and you're not getting the result that we all wish that you had. So it's important to put things in the proper order, obviously.
Well, and somebody's breasts are really massive. It is impeding their health in that they can't exercise.
Right.
And the neck and back pain are real. So it's a juggling act.
Sure. And the drain question came up for breast reductions as well. I have never used a drain for a breast reduction. I don't know if you do that regularly. So that shouldn't be a concern either. I know people hate drains, hate scars. There's all sorts of things that people don't like. Can we do a mini tummy tuck with liposuction? It's done all the time. Absolutely.
All the time.
Yeah, it's a great combination of procedures to help you shape if you're a good candidate for it. And so what you have to evaluate is you have to make sure that your problem is just kind of from your belly button to your pubic bone. That's what a mini tummy tuck will rejuvenate. And then the addition of liposuction to either the upper abdomen or the flanks, or the hips, or the lower back, all that area, that's a great combination of surgery and can do a lot of good for people. I've got a question that says, can an upper thigh lift be done without the scar that goes along the groin, with the scar along the groin, and not down the thigh? Yes. So that's called a crescent lift. You want to talk about the difference between a crescent lift and a medial thigh lift?
Well, a crescent lift is a horizontal along the groin area, and it has limited effects.
It does.
Whereas the incision that's a thigh lift goes from basically the knee up until the groin, so it's on the inside portion of the thigh. Much more powerful, but a much bigger scar.
It is. It's a bigger scar, and you really have to look at where the laxity is, right? So on physical examination, we'll be able to kind of recreate for you the power and the power difference between those two surgeries. Some people really just have this zone where their thighs, the upper portion of their thighs, hit each other, right? And there's that kind of, everybody wants the thigh gap. I know that's huge, and every woman longs for it. And it was all the rage a couple of years ago. People would come in and say thigh gap, and girls were getting liposuction of their medial thighs for their graduation gifts to get thigh gap. I mean, the world got pretty crazy even before COVID. That's right. Thigh gap, very important. And so if that's the only area that has laxity, then a lot of times you can place an incision in the groin area, and that's that crescent thigh lift. And the vertical thigh lift is for the patients that typically have lost a whole lot of weight and have laxity kind of all in the vertical and horizontal dimension. And there's some patients who are a better candidate for the vertical thigh lift, but just really don't want that scarring up the crescent lift, and they'll get improvement, just not to the same degree, of course, that you would get from a vertical thigh lift. So I hope that helps with that. How long do you have to be out of work for a breast reduction? What do you typically tell your patients for how long they're out of work?
I think if they have a sedentary job at a computer or a desk, I think 2 weeks is plenty.
Okay.
I think if you're more physical things, I would say 3 to 4.
Right.
And I comically say, well, if you work for yourself, you'll be back to work the next day. If you work for the government, it'll be 6 weeks.
That's right. So similar kind of timeframes with patients, with a lot more people from COVID working at home. I basically tell them, if you're not going into the office, breast reduction surgery is one of these surgeries that's so gratifying for both surgeon and patient almost immediately, because you're sore. You know that you were operated on.
That sore.
Right. And so I typically say the first couple nights, maybe you're taking a pain pill to help you get through the night. And then it's kind of Tylenol. And then once we're a few days out from surgery, you can kind of go to ibuprofen and Advil. You're wearing a bra to help support your tissues, which alleviates, if we just kind of did your surgery and you went braless, then gravity would have an effect on your suture pulling and all that. So, you're in a comfortable bra. And I tell patients, so long as you're not on pain meds, you can work from home and work from your computer and make decisions that you would normally make at work, so long as they're not muddled at all by, I wouldn't want you to take a pain pill and then go make some financial decisions, right?
What do you say about driving?
I say when they're not on pain meds, and this is something where, we can't prevent.
What if they live in Hollywood?
Well, they say, can they drive safely? My first question is always a smart ass question. I always say, I don't know, could you drive safely beforehand? Right. So that's what I say at the beginning. But, so long, people have to live. And even with COVID and kind of the change of pace and being able to do things more at home now, you still probably have, you got to drive to the store, you got to drop your kids off at school or the bus or any of those types of things. So long as you're not on pain meds, I don't have a problem with you driving, right? I mean, these aren't big rig movements that you're making with your arms when you're getting a breast reduction surgery. And, we're not doing anything to your muscles. So long as you're keeping your blood pressure and heart rate down, I tell patients, you can drive, you can go back to work, you can do those types of things when you're not on pain meds. Now, from a physical activity standpoint, I tell everybody, 95% of complications happen within the first 2 days. And then 4.5 of the remaining 5% happen within the first 2 weeks. So that's why it's critical for me for 2 weeks, blood pressure, heart rate are kept down. And then that 2 week zone, I start letting any of my patients, breast augmentations, tummy tuck, breast reductions, breast lifts, liposuction. You can start walking as an exercise, like with power in the neighborhood. But I still don't want too much up and down jumping movements or any of that kind of stuff.
Vacuuming, raking, mopping, sweeping, tennis, golf.
Right, absolutely. How soon after breast augmentation would I be able to go to the beach or pool?
You may not be able to stop yourself if you look that good 1 day later.
Right.
I think those things are all safe, but again, you can't do those activities that get your heart rate up, because that gets your blood pressure up, and that can make you bruise and swell and potentially bleed, which could theoretically get you back to the operating room for an unnecessary that procedure.
That's nipple, I know.
It's not dangerous bleeding, it's nuisance bleeding, but it delays your healing. So there's no advantage to pushing the recovery too fast. It can hurt you.
Yeah, and what I typically tell patients, is their question is, when can I get in the water? Right, and
you go look good at the beach right away.
You can look great at the beach right away.
It'll take 2 or 3 weeks for me on the water.
Yeah, I think it depends on the water.
Incision's got to be healed well.
Incision needs to be healed well. We also have occlusive dressings that we can, have you pick up at CVS. We'll give you a couple from here. You can put those over your incisions, of course. And then, there's dunking under the water in a chlorinated pool and the ocean, and then there's jumping in Lake Wiley. No offense to Lake Wiley, but those are different kind of scenarios.
It's just not worth a lot of risk. You put a lot of expense and time and energy. Why take any risk at all is my position.
Agree. And I think, after a breast augmentation, obviously you're going to feel pretty great about things, and you're going to get in that
look good in your bathing suit.
That's right. Go sit by the pool or
in the shade with your sunscreen.
That's right. Sunscreen, very important. What else do we got?
How about eyelid questions, face questions, neck questions, brow questions, laser questions, hair removal questions, non-invasive facial tightening questions, cool sculpting questions, Botox questions, filler questions.
This lady has asked, how soon after breast reduction can I pick up my toddler? So a lot of kind of post-operative recovery questions are coming in. I'd say it depends on how big your toddler is. One thing. And then I'd say, moms have incredible abilities to lift children up in many different ways, right? I mean, my wife, I felt like she would sometimes use the side of her leg, and all of a sudden she'd have 2 kids up on her hips. We call them mom muscles. Like dads have dad muscles. Moms get mom muscles. So long as your child isn't putting all of their weight, or coming off the top of the couch with a a Jimmy Superfly Snuka elbow to the breast, I think you're fine to hold your child and toddler and comfort them. We don't expect you not to,
A lot of that will be
off.
self-limited because your breast will be somewhat tender, and
Sure.
you're going to be defensive about that. So I think your good judgment will guide you.
Definitely. All right. What about? All right. So talk a little bit about PRP. And a little bit about what kind of we've been seeing with patients, both men and women, who have wanted to do some PRP injections. What is PRP? How many times do they need to come back and do it? And what type of results are we seeing with PRP for hair restoration in these patients? Because PRP's been around for forever, right? They've been injecting it in joints. They've been using it in all different
Your
places.
forever and my forever are different. I think it's probably been around for 10 years, and I think we use it. We have a specialist that comes in and does PRP injections to the scalp, and I want you to correct me if I'm wrong. I think she's got some very nice results that are, again, you have to be a good candidate, and she will evaluate you for what your pattern of hair loss is, and can show you results that you'll either evaluate and go, wow, that's amazing, as I have said, or well, that's not what I was looking for. She also can do that in conjunction with hair transplants. I think there are, is it a series of 3 injections and then like twice a year after that?
Yeah, so everybody will, it'll depend upon, I've gotten PRP injections myself, and so I can absolutely 100%.
I did, it didn't work for me.
Yeah, right. He didn't, so don't take that as seriousness. Stacy is amazing, right? And so Stacy is kind of our one-stop shop for hair. Not only will she do hair restoration through PRP injections, but she's extremely talented at hair transplantations, right? These don't look like plugs anymore like they did 20, 30 years ago. It's very natural. And she also does laser hair removal. So, I mean, if you want to get rid of some hair in certain areas and add hair, it's like, Father's Day is getting ready to come up.
And, the hair removal that I used to do with laser, because I'm a little furry, as you might tell, it hurt and I couldn't go through with it. But the machine we've got now is virtually painless. I've had 2 treatments. My wife tells me it's amazing.
Right. So great. You don't really look back there. So
no, I don't.
Right. Yeah.
But so I would, that thing's pretty great.
It's pretty phenomenal, and I've had that as well. There's no way that the barrier to laser hair removal
used to be pain.
And so I've had several friends in the community. I have several people who say, oh, I tried laser hair removal, and I stopped after the first or the second treatment. And then you're not treating the hair follicle throughout its cycle, so you're really not killing that hair at every kind of stage of its growth, right? The anaphase, mesophase, telophase, all those things. So it's one of these things where, you've got to treat for a period of time. It's just like, we take antibiotics for a length of time to help kill the bacterial cell cycle. So similarly with this, you've got to come back, and the barrier of pain is eliminated. So if your laser hair removal doesn't work, it's because you're not being responsible and you're not coming back to get it done. Or if you have, blonde, gray hairs, any of those types of things.
What is it? You come back every 8 weeks?
So it depends on your treatment plan. Some people are every 4 weeks. Some people are every 6 weeks. You typically want to treat hair, within this 6-month time frame, right? And then you really have things covered. A typical kind of hair follicle is like 120 days. So you want to catch that. If you do a 6-month kind of situation, then you're there for 180 days, and you're going to catch hairs that are on kind of either side of that cycle, and you really get to kind of overlap yourself. So we typically tell people, 6 cycles, especially if you have really coarse, thick hair, and then you may need some touch-ups from here and there. But I mean, I had my entire back done in less than 11 minutes. So this is not an individual, laser pop.
So that 90 minutes I had to do was bad?
She just didn't like you.
Okay.
Yeah, that's all it was. She just wanted you to have to sweat it out, literally. Okay, we've got a question that says, will the nipples be erect more often after a reduction? How can I prevent my breasts from growing back? So nipples erect.
Can be erect.
Yeah, and I wonder if what they're talking about is sensation to the nipple, right? The old kind of teachings are, you know, it depends on how big of a reduction you are. The larger the reduction, the more opportunity there is for superficial nerves to get removed in the resection portion of this. But typically, a third of patients have a decrease in nipple sensation. A third of patients have no change, and a third of patients can have an increase in nipple sensation. Now, there are some people, if we're talking about erect nipples, that have inverted nipple deformities. So how do we correct inverted nipple deformities in patients? So these are patients that their nipples look like they are tucked inwards. Any nipples. How do we address those patients?
I think that inverted nipples, as long as you make sure there's not a tumor involved, which is the first thing you want to make sure of. And a lot of times the history is, you know, I'm 23, I'm 43, I've had these all my life, and I'm just tired of it.
Sometimes it's one side.
It can be just one side, and it is the duct, that is the milk duct that's taking the milk from the milk gland to the outside, that is shortened, and it's pulling the nipple in. So we will go in through an incision at the base of the nipple itself and just cut all of those ducts.
Right.
And I don't know how you do it, but then I'll put a stitch, sort of a little horseshoe back and forth stitch that interposes the sides of the nipple together so that the ducts can't kind of grow back together.
Right.
And you can do it in 10 minutes.
And you can do it under local. You don't have to go to sleep for this. You know, I sometimes am pretty conservative. I hate complications. Every surgeon gets them, but I try and minimize them. So, you know, if we're doing a breast lift on somebody and it's a challenging lift and we're really kind of moving them a whole lot of distance, sometimes I'll wait and I'll do the inverted nipple correction, you know, 3 months down the road under local for the patient. I do the exact same way. I use 4 little small nick incisions at the base of the nipple. I cut those glands or the Cooper's ligaments or whatever's kind of holding that nipple in, and then I do that interposing stitch, and then you know, it's a really gratifying surgery. I mean, I love taking before and afters on the table because it's like, here's it in, and then 10 minutes later, here's it out. So
complimentary tassel.
That's exactly right. Yeah. And then we put a bolster dressing on there so that there's no pressure over your nipple for the next week, and you look like a fembot from Austin Powers, where it looks like little gun kind of barrels are coming out at you. So that's great too.
Any cool sculpting questions yet?
So no cool sculpting questions. I do have a question about how do you typically treat brown spots on the face that are resistant to prescription whitening creams?
Again, diagnosis is important. Some of those brown spots, if they're superficial, we can get them with the IPL laser. If they're deeper, it's not going to work. And what they may end up being is melasma. And melasma is a hormonal thing, got to do with estrogen progestin in the skin. Typically happens in women in childbearing areas or times of their life. And it really doesn't, you can make it better, but you can't make it go away until their hormones change in menopause.
Right.
That, at this point, is our state of knowledge of it in the treatment area. So it may be not satisfying, but that's what we got.
Right, and you know, the IPL laser that we have here is great for brown spots, great for vascular lesions on the face, the little kind of cracked blood vessels that I need to go in there and let them take care of.
And if it's a, you know, if it's a nevus, a mole, that's not going to go with bleaching creams, but that, you know, diffuse color change that's deeper is melasma.
Sure. This says, I've had 2 C-sections. How much bigger, and I presume longer, is a tummy tuck scar than a C-section scar? And will I have less recovery pain having already been cut?
I'd say, for me anyway, I say C-sections are about the same. Some say tummy tucks are worse, some say they're better. So I say it's in the neighborhood.
Sure.
And, you know, if you have a lot of skin to be removed, your incision has to be longer to be able to get all the extra skin out and not leave what in sewing terms is called a dog ear.
Right.
So a lot of times that's hip to hip, but it's in the bikini line. So
right.
I got lots of pictures of people wearing bikinis with tummy tuck scars.
Sure, and I've got patients that have had circumferentials all the way around to rejuvenate their lateral thighs or their buttocks, and when they're in their bikini, you can't see any of it. And that's my same answer to patients when they say, how long? And I say, well, the kind of smart aleck answer is long enough to match up and share the excess length that you have by how much tissue needs to be removed. And so
sort of geometry.
And we can give you an estimate. Everybody we can kind of estimate, but it's certainly longer than a C-section scar typically, especially if it's a full tummy tuck.
And those scars are a great trade-off.
Right.
If you've got lots of extra skin, if it's all got stretch marks in it, there's the associated fat, and that's an incision nobody sees.
Yep.
You know, and even let's call it a bikini, but let's don't call it a string bikini. It's a wonderful trade-off,
right.
And you can't do it with diet and exercise.
This prospective patient wants to know, can you discuss the options for non-invasive fat removal of the abdomen?
Well, you and I have been talking a lot about that lately.
A lot.
And we have used cold sculpting since 2012, yep. And it does work. It is not as powerful as liposuction. By any means, you're going to do it 2 or 3 times. And that sounds bad if it was surgery, because doing liposuction 2 or 3 times would be a big deal.
Right.
But this is come in, have this device put on your tummy. It freezes so fast you can't even feel it. You sit there for 37 minutes and the cycle's over and you get up and go about your business. There's no anesthesia, there's no downtime, there's no incision, but it's more gentle. So most need to do it 2 or 3 times, right. Unless you get a tiny amount of fat. You're going to do it twice, but that's not really an issue because it doesn't stop you from doing anything. When I did it, I went and hit some golf balls and pumped some iron immediately afterwards. Yeah. You see your results in about a full result in 90 days, and you can, if you know you're going to repeat it, which most do, you could do it again at 30 days. Right. You come in your lunch hour, you can do it so many different ways. Right. Now, you went to a seminar last night.
I did. And so there's obviously non-invasive is key, and patients want to get as much done with as little invasiveness, with as little scarring as possible.
But again, mild results.
And I get that. And the results have to be compared to other non-surgical means, right? So cool sculpting is tried and tested, and we know that it works, right? There are limitations for it, but it works. And then there's other ways of dissipating, getting rid of fat through heat, right? Sculpture was one of those ways that they did it. There are other modalities with products that kind of combine RF heating to try and heat up those fat molecules so that they then, some of it sounds a little bit like witchcraft, but they somehow dissolve, break up, and the body takes care of it. And so,
isn't that witchcraft?
A little bit, it might be. I think they see some results. People see some results. Obviously, if we felt that some of these technologies were solid and we felt like we would put our name on them,
well said,
we would buy it.
Yeah, and I don't think we're there yet.
We would offer it, and we're not there yet. And technology continues to improve, right? I probably would not have wanted to buy the first all-electric car, right? But I'm on a list now to get one. So it's like you kind of wait, you get a feel for things.
And
you
I
let
thought
the
first time I
technology
heard cool sculpting, I thought, what a joke!
Right.
Another gimmick in the plastic surgery world.
Right.
But it definitely has stood the test of time, and these newer things we hope are going to be as good or better.
Right.
And we're not ready to say yet that they are. We hope they are.
Correct. How about the best method to remove forehead wrinkles?
The simplest one's Botox.
Right.
Brow lifts really don't get the wrinkles to go away. They could, but it's risky. So what brow lifts do is they elevate your brow position, which makes you look more youthful, more feminine. So you have to watch out with men when you do that. Right. And it also makes the eyelid look better. Right. It can make the wrinkles between the eyes, the 11s that we call them, you can make those better because you're going to remove those muscles, and you don't need those muscles to scowl. You can still scowl. If you scowl 10% of your total scowl capacity, that's enough.
Right. And moms typically have that look in church when your mom would look at you and you knew.
Even if you got Botox in there, you're being scolded. Brow lifts are a wonderful thing, but to make the wrinkles go away with a brow lift, you'd have to cut the nerves.
To pull pretty tight.
And that's a risky thing. That are you going to cut them too much? Are you going to cut them symmetrically? Does your brow move anymore? Does it actually fall because the muscles are de-innervated? So we don't cut the muscles, or excuse me, we don't cut the nerves.
And Botox is great, right? That's the shorthand answer. It's great. It not only erases dynamic lines, which are lines that you have when you animate your face, but also static lines. I remember when, before I started doing Botox, I had pretty deep creases in the middle of my forehead, and I was worried that those wouldn't go away.
Because they don't look good with a ponytail.
They don't look good with my current man bun.
Okay. And
so, but the good thing is with this much hair after PRP, I can just put it all in the front.
Oh, stop talking about too much hair.
So it's one of these things where Botox is fantastic. People freak out about Botox. They worry about Botox. They come in with perceptions that are easy to kind of redirect. And we happen to have like 3 of the best nurse injectors you're ever going to meet, right? You cannot go wrong with any of them. Literally, one of our lead nurse injectors is the one that the Botox company sends to teach other people across the country how to do it, right? And so obviously she has taught and learned from, I'm sure, just as we both learned from each other, the other 2 injectors, and they're fantastic. And so, I know how I was trained how to do Botox, 10, 11, 12 years ago in residency, and I don't even do it. I'm never going to Botox you. And the reason why I'm never going to Botox you is because I have 3 people here that are better at it than I am. So why would I ever do it? But they learn new technologies, right? Like they went to a cadaver lab in like Oklahoma or Nebraska or some Midwestern state and like went through this entire cadaver course to learn new places to use Botox. Safely. And it's right to do it safely, but also, how to help turn lips up and how to get rid of that orange peel kind of look to the front of the
peau
chin.
d'orange.
The peau d'orange. All these things are techniques that, 10, 15 years ago, we wouldn't have known what to do. And now you come to Graper Harper Cosmetic Surgery and see any one of our nurse injectors and they will fix you up right. And it's great.
They're good.
Yeah, they're absolutely fantastic.
It's a good short answer, Botox.
That's right.
And some people come in every 3 months because they never want to have a wrinkle. And other people's strategy is, the holidays are coming up, so I'm going to get my Botox about Halloween. It's going to last me all the way through all the holiday events. And now that COVID is getting close to being over, we heard today.
No masks.
No masks.
Well, we're vaccinated. We're vaccinated.
Inside or outside, no masks. So tell your friends if they haven't been vaccinated, get vaccinated and get rid of that mask.
That's right. No distancing, and we're probably 4 feet from each other now instead of 6.
Oh yeah, but we could be 2 feet.
You don't have to distance anymore. It's fantastic.
Don't even think about it.
I'm not. Don't worry. All right, and then another question, multiple laparoscopic surgeries, have a lot of scars on my abdomen. How would these scars, if all, impact having liposuction? So, the scars for laparoscopies tend to be perpendicular to the plane of your skin, right? So they go straight down because they need to get the laparoscope inside your abdominal cavity, so there's not a lot of tunneling. And so theoretically, I'd love to use those same scars. I don't want to put any new ones on you, but unless on physical examination we feel that there's a lot of scar tissue buildup underneath there, you can actually start the liposuctioning process, not even on suction. We use what's called a basket cannula to help break up some of that scar tissue, and it lends otherwise kind of scarred abdomens. It makes it more accessible for what we do.
Yeah, I think if the skin's mobile and not tethered, and if it was tethered, you try to break it up with that basket.
Right.
And you wouldn't really know you could do that ahead of time, but most likely the overall effect would be very good or beneficial and worth trying. But again, we need to look at the individual case.
Right. So this is, I guess, let's see how we'll wrap our head around this. This particular prospective patient said, I have a large space between both nipples. Will I be able to make my breasts appear closer together without having my nipples moved.
Will the nipples look closer or the breasts look closer?
Right, because the breast can obviously look closer as we add cleavage through something like an augmentation, right? But if we're not doing a lift and we can reposition nipples, sometimes nipples are out lateral and we need to bring them in. It's much harder if they're in to bring them out. And so, we can reposition nipples through incisions, and that's a lift. And so we'd have to reduce the amount of skin between the cleavage line and the nipple to recenter that nipple, if that's the case. But if you're talking about getting your breasts to appear closer together, then yeah, I mean, an implant will bring your cleavage together and make your breast look fuller medially, without actually physically bringing your nipples closer together by measurement, if that makes sense.
Yeah, I think that makes sense. What they need to think about, though, is when you do that, and I have seen that, the nipples actually look wider,
right,
and like they're pointing out, and it's an unusual look that I don't know that most patients would actually like. So,
right,
part of it's better because you got cleavage, and part of it, the nipples are way out to the side like that, which is also an unusual look. So we'd like to talk about that, maybe simulate it on the computer.
Simulations can help with that. What I tell patients is the nipple can look lateralized if there's a paucity of tissue to the lateral breast, right? Like there's some people who don't have a lot of side boob, who the shape of and the border of their lateral breast don't go outside their chest wall silhouette. And that's kind of a manly look. And so most people, when they show photographs or when we talk about that, like what are the ideal kind of breast ratios, parameters, measurements, those types of things, have a little bit of side boob. And I'm sorry for not having a better technical term, but that's certainly just
is this as good as
what
thigh
it's
gap?
called. This is as good as thigh gap. So that side boob, if we increase the side boob,
SB,
the SB, then the nipple looks more centered, right?
Yeah.
And so because if we've got tightness over laterally and a nipple that's in this position, well, the only way to make that nipple look more central to a breast is to build the volume out laterally, right?
Without making a scar.
Without making a scar.
Yeah. And I don't think that patient would like that scar.
I don't think so either, unless they were low and needed a lift.
Yeah, if they were low, but if they're at the appropriate angle,
right,
then that's
right. And then if you afford us the opportunity to use, the traditional wise pattern incision, which is the anchor incision, we can move breast tissue almost anywhere. I mean, it really allows us to three-dimensionally kind of reshape the breast, which is typically what most patients need,
How are we doing on time, ladies? Okay.
2 minutes, that's it? Oh, man. Well, I think we've answered most of the questions that people have. So because I bought this bottle of whiskey, I'd like to know what you think.
I think it's very smooth. I think it tastes remarkably like whiskey.
It does.
It does. And I would have another.
Good. So some whiskeys taste a little different. They didn't call it a bourbon because they're from Wyoming, so I appreciate them respecting that. But I think it's great. It's 100 proof, ladies. Father's Day's coming up.
And, you gotta like the Western flair.
You do.
What's the other one? The High West.
High West. Yeah, High West is a great one. Yellowstone has a bourbon out. There's a million different distilleries and bourbon companies, but the folks at State Line, or there's tons of great ABC stores in North Carolina.
Would the ABC store in North Carolina have that?
Probably not, but State Line has it. I'm sure probably Southern Spirits in Indian Land. It's another fantastic place. Mm. So somebody was asking me the other day for a Father's Day gift, and
South Park? No, you're not going to find that in South Park.
Probably not. Because North Carolina is all ABC run, and so they kind of get what they get, and you don't pitch a fit. But Wyoming whiskey is 100 proof. It's great. I highly recommend it, and we appreciate everybody coming out.
Cheers.
Spending their time with us, right? Cheers.
Call us. Consultation is breast.
Yeah.
So don't feel bad about first words out of your mouth calling out for a consultation is breast. I want the breast special.
That's exactly right. Even if it's not breast, even if it's tummy or
Well,
something
right.
else. Yeah. Even if it's like Botox, just say breasts and we'll give you all the specials.
Yeah.
Right?
And we'd also like some feedback on whether you like this format better than having to be right here with us in our reception area. We think this is better. I think it's easier.
Yeah, we like it. And then we don't have to, you know,
We can drink.
get too dressed up and we can drink. That's right. All right. Cheers.
Cheers.